Good evening, everyone, and attendees and the chairpersons at this meeting, CardioCon 2023. At the outset, let me congratulate Dr. Kamal Sharma and the organizing team for inviting me for this talk. Moving forward, the title of the talk is about the high definition intravascular ultrasound. As we know, the intravascular ultrasound, the sound-based imaging modality, the in vivo clinical use has been described from 1988. The system involves a catheter mounted with piezoelectric crystalline transducer, which generates the sound waves, and there is a differential reflection of sound waves, which are generated cross-sectional 360 degrees of grayscale images of vascular structure. Ever since its inception over the last 2 decades, there has been several data, both from randomized clinical trial as well as registries, about its impact during the angioplasty. Namely, some of the large clinical studies like IVUS XPL, Ultimate, CTO, IVUS, and several others which are comparing with optical coherence tomography, including Illumian 3, Opinion, and ROC2. In all of these studies, the impact of coronary imaging over precision angioplasty has been found to be profound. If we simply examine the 5-year follow-up of IVUS XPL randomized clinical trial, the MACE rates have been significantly affected in a positive direction with the use of coronary imaging, and the impact has been seen as early as less than 1 year, has remained significantly diverging as far as the outcomes are concerned between 1 and 5 years, and at the end of 5 years as well. As is clearly seen in this Kaplan-Meier estimates of occurrence of primary endpoint for all patients and for patients who underwent intravascular ultrasound guided stent implantation, one can clearly see the curves diverging and continue to diverge over a 5-year follow-up as far as the major adverse coronary events are concerned. The conclusions from IVUS XPL clearly say that with the use of IVUS guidance, there is 50% relative risk reduction as far as the MACE rates are concerned, and curves continue to diverge between 1 and 5 years. So there has been sustained clinical benefit of image guidance, not only in short term, but also in the intermediate to long term. It also underlined the fact that impact of IVUS is not only use dependent, but what the decision as a clinician one makes and improves as far as precision in the steps of performing angioplasty. That matters more, simply rather than the use itself is concerned. Based on this kind of clinical data, the APC-AHA guidelines have designated coronary imaging with intravascular ultrasound as a class 2A indication for use in patients for optimizing the stent implantation with PCI, as well as to assess the severity and optimize the treatment of unprotected left brain disease. Now, going forward about the high definition intravascular ultrasound. The intravascular ultrasound imaging modality actually involves coronary imaging catheter, which has been provided with a piezoelectric crystalline transducer. Now, this transducer in HD-IVUS has been provided now with a 60 megahertz of advanced composite transducer. And what it does is that the 60 megahertz transducer allows wider tissue band, wider band of the sounds transmitted, and that leads to a much better image resolution. With a similar degree of vessel penetration, the clarity as far as the vascular structure is concerned, the imaging of vascular structure is concerned, has been tremendously improved. If you see in this chart that with the help of 60 megahertz of high definition intravascular ultrasound signals, the axial and lateral resolution is tremendously improved, and it almost matches to the infrared based optical coherence tomography. The soft tissue penetration improves, and a vessel as large as 6 millimeter can be easily evaluated with the use of HD-IVUS. We just look into some of the images which are being generated with HD-IVUS. One can clearly see that with the 60 megahertz coronary imaging catheter, it provides much crisper images in comparison to 40 megahertz coronary imaging catheter. Both axial as well as lateral resolution improves. As far as the stent visibility is concerned, naturally with the help of 60 megahertz catheter, it shows a much clearer resolution confirmation of adequate stent expansion and apposition to the vessel was as seen in these images. The upper sets of images are comparison of visibility of the stent compared to 40 megahertz versus 60 megahertz, and in the lower two images, what we can see here is a side branch origin, and one can clearly see even the adequacy of the side branch ostium and jailed wire in the side branch. With the help of 60 megahertz HD-IVUS catheter, one can comfortably visualize a large vessels as large as 6 millimeter without sacrificing the image quality. So this picture clearly shows the clarity of the image as far as the large vessel is concerned. And that gives an additional comfort as far as evaluation of the large vessels like left main coronary artery or ectatic coronary artery or positively remodeled vessels assessment, making it much more precise. If you see the comparative assessment with OCT, uh, here there is there are these two images are showing comparison between HD-IVUS derived image versus OCT derived image, and one can see that the uh, determination of intimal thickness is almost equivalent as far as OCT is concerned and HD-IVUS is concerned. And this also shows adequacy of the side branch ostia, which can be evaluated easily even with the HD-IVUS. We have some of the other examples of 60 megahertz images derived from HD-IVUS. And here is the image which clearly shows the mal-opposed stent struts between 9 o'clock and 12 o'clock position. Even smaller degrees of malopposition also can be evaluated much more reliably with HD-IVUS. These are some of the co-registered HD-IVUS images with optical coherence tomographic images of native and stented coronary artery segments. And one can see not only healthy vessel, but fibrous plaque, a lipidic plaque, the stent struts evaluation when there is malopposition of the stent struts, the calcium behind the surface of the stent struts, as well as the age dissections. They can be reliably inferred, detected with the help of HD-IVUS. The detection of vulnerable plaque, wherein detection of a thin crepe fibroatheroma has been an important component as far as the assessment of vulnerable plaque is concerned. And HD-IVUS reliably detects even the thin crepe fibroatheromas with a necrotic core. This is the comparative images showing OCT image versus the HD-IVUS generated images. Detection of calcification, as we know that the calcium does not allow ultrasound waves to travel far, and therefore the tissues behind the calcific plaque cannot be reliably seen. However, with the help of HD-IVUS, we can differentially see calcium located near intima and calcium located near the adventitia. Of course, the tissues behind the heavily calcific plaque, a thick plate of calcium, may not be adequately seen. However, the reverberations of the calcium indirectly suggests that yes, the calcium has been superficial. Of course, the thickness of calcium cannot be reliably assessed with the ultrasound, intravascular imaging, with the IVUS. However, to a great extent, as far as treatment decisions are being taken, IVUS also helps in reliably choosing your tools, how you go ahead with the plaque modification. Extent of plaque burden as judged by IVUS is also comparable and reliably assessed as compared to the OCT. And we can see a significant plaque burden from 9 o'clock to 4 o'clock position, and heavily lipidic plaque is seen over here. Stent malposition between 4 o'clock and the 6 o'clock position, again seen reliably with HD-IVUS, and the images are almost comparable to the CT. And similarly, the extent of malopose stent and under expansion also can be reliably assessed with HD-IVUS. Coming to neoatherosclerosis, these are comparative images of assessment of neoatherosclerotic tissue with HD-IVUS versus OCT. And one can clearly see in image A- here, twin layers of stent struts showing stent fracture. Here we can see adequate stent expansion, but there is calcification within the neoatherosclerosis from 1 o'clock to 5 o'clock position. And here one can see a lipidic plaque rupture within the neoatherosclerotic lesions. If we talk about instant restenosis, definitely the optical coherence tomography scores over the HD-IVUS, except for the instant restenotic lesions. Majority of other complications can be reliably still detected efficiently with the help of HD-IVUS. Images clearly showing in the intramural hematoma, the component of the intramyocardial bridge, and even the large coronary aneurysm. They all can be detected very easily with the help of HD-IVUS. Based on this precision of imaging that as an operator one tends to get access to, if we look into the IVUS 1, 2, 3 essentials, which is based on the pre-stent workflow where we need to establish lesion length and define landing zones. We need to assess plaque morphology and measure the vessel size. And the post-stent workflow where we need to look for geographic miss, age dissection, we need to check for malposition, and also look for optimal stent expansion. In all of these steps, both pre and post stent workflow, the IVUS has been an essential tool, especially the HD-IVUS. If you look into the similarities and differences, there is a very popular slide which shows differences and similarities between IVUS and OCT. And except for tissue protrusions through the stent struts, stent malposition, some areas wherein the stent edge dissection may be suboptimal, and assessment of neoatherosclerosis. Except some of these aspects, which are very well assessed with OCT much more reliably as compared to the IVUS. In rest of all parameters, if we see, definitely the intravascular ultrasound with the HD IVUS scores and is comparable to the OCT. So IVUS or OCT, that question always arises as far as employing the coronary imaging in PCI is concerned. So I would say that the better resolution of 10 to 20 microns and intimal surface details at times favors use of OCT. But if you look into the assessment of large vessels like left main, osteal disease, diffuse disease, wherein vessel sizing is very important, and here one needs a better penetration of ultrasound waves to assess them, and therefore in such scenarios, the intravascular ultrasound with HD-IVUS will score over OCT. If you have to assess stent under expansion, both imaging modalities are almost equivalent as far as HD-IVUS and OCT is concerned. But if you want to assess plaque volume, morphology, and residual plaque burden at stent edges, and when we look for vessel sizing, definitely IVUS scores over OCT. For assessment of calcium, malposition, and stent fracture, OCT may have a little more edge over IVUS. And assessment of patients with ISR, especially the residual plaque burden at stent edges, and those patients who have impaired GFR, IVUS will have a little edge over optical coherence tomography. As far as neoatherosclerosis is concerned, yes, definitely the OCT will be a better tool as compared to the HD-IVUS. Barring all these differences, it is safe to conclude that HD-IVUS is essential for certain clinical subgroups. Most importantly, the left main disease, osteal disease, diffuse coronary atherosclerotic burden, those patients with the chronic total occlusion with a proximal cap ambiguity, where deciding the false lumen and true lumen is important, and proximal cap puncture when it is technically demanding. In all those situations, HD-IVUS is an essential important tool for the procedural success. And of course, the importance in preserving the contrast load in patients with CKD and in patients with LV dysfunction cannot be overemphasized. So I think in these clinical scenarios, the HD-IVUS is going to score over optical coherence tomography and is going to be an essential tool as far as precision angioplasty is concerned. Thank you for the patient hearing.